Welcome to Academy of Ultrasound. I'm John Sheldon, and I'll be your instructor for this evening, for this session. Tonight we're going to talk about Echo233 week 2, which is dealing with Chapter 7, How to Evaluate LV Diastolic Filling in the Essentials of Echo book. Specifically on page 224 is where we're starting. If you'll remember from week 1, we talked a lot about diastolic filling, what it is, the normal M-mode patterns, the normal mitral inflow patterns and pulmonary vein patterns that you should expect. Now I want to go ahead and start talking about diastolic filling, mitral inflow, some common patterns that you'll run into. The figures on the top of page 224 that you need to be made aware of and comfortable with, because you'll see these on reoccurring patients throughout your career, would be rapid filling. It's a very large E, small a. Looks kind of similar to the restricted filling. However, there's other things that go along with this, such as your deceleration times, your tissue Doppler, things that we'll look at. The main thing to be aware of if you have a 10 to a 30-year-old is that this is a rapid filling pattern, and it is common, but it is still considered to be normal. Normal filling for a 30 to 50-year-old is your typical EA, where E is slightly larger than A, and you have your week 1 dealt with the specific EA ratios and calculations or information numbers that you need to be made aware of. Then you get into greater than 50 years old, you typically, assuming they have no other cardiac problems, they typically will have prolonged relaxation, which is your EA reversal, or also known as grade 1 diastolic dysfunction, grade 1. Then you have what's called as pseudo-normalized. Pseudo-normalized is referred to as grade 2. And what that is that basically on the face of it, it looks like a normal filling pattern. However, you'll have some other issues that will come along that will indicate to you that it might possibly be a pseudo-normal instead of normal. And what we do then is to do a Valsalva maneuver where you have the patient actually take a deep breath in, bear down on their stomach, such as if they were to pretend like they were going to the restroom, going to the bathroom, having a bowel movement, and tightening up that abdomen, increasing that abdominal pressure, will actually change that pseudo-normal into a prolonged relaxation waveform. So it will change with Valsalva. Then we have the restricted filling, which is referred to commonly as left heart failure, or beginnings of left heart failure, and that's referred to as 3 or 4. The difference between 3 and 4 is dealing with whether it's reversible or not. If it's restricted reversible versus restricted non-reversible. Down at the bottom, you have your indices of diastolic filling with your pulmonary veins. Again, you have your S, your D, and your R. Be aware of what an S, D, and R in a normal patient looks like. Sometimes you'll have this situation where you have what's referred to as a biphasic, and they're quoting approximately 37% of patients. Your S will actually have 2 peaks instead of 1. That's normal. That's still considered a normal variant. Your normal and abnormal range on your pulmonary veins. Your normal, you have your S, your D, and your R. If the S is substantially longer than the D, that corresponds to the diastolic function up here referred to as prolonged relaxation. If your S is very small compared to your D and your R has gotten bigger, then that refers to the restricted, also up here with your EA, restricted. So you need to be aware of your mitral inflows as well as your pulmonary vein flows. You don't necessarily have to know the SD ratios and the reversal times in milliseconds, but they're given here. You need to be aware of the waveforms, the normal waveform versus the prolonged waveform versus the restricted waveform, so that when you're checking pulmonary veins, you can very quickly determine whether they are normal, abnormal, pseudo-normal. All right, so let's move on to page 226, which is common patterns. You have your rapid filling of your 30-year-olds. That's where the S is tiny, big D, R. Remember, if it's a 10 to 30-year-old, then it's not abnormal. It's just rapid filling. You have your normal in a 30 to 50-year-old. The S and the D are closer to the same size, and you have a tiny R. You have your prolonged, which corresponds with grade 1 diastolic dysfunction. Your S is very large, smaller D, little r. Elevated left ventricular end diastolic pressure. When the S and the D start to become the same and your R starts to get larger, this is in between the prolonged and the restricted. This is the step in between prolonged and restricted. It's worse than the grade 1. It hasn't quite made it to restricted. When you get to restricted, you have a little tiny S, a big D, and a big R. That's the difference between the 10 to 30-year-old and the left heart failure patient. You have a large reversal. So your normal diastolic filling mitral inflow and pulmonary vein, age less than 20, greater than 20 and less than 55, there's an inverse relationship between the E and the S. You have a big E, a littler S. You have a smaller A, a larger D. Big E, small S. Small A, large D. So they're in an actual inverse relationship. So let's move on to page 227. When you're dealing with prolonged diastolic filling, again, you have that same basic relationship. In this case, the E is smaller, the S is larger. The A is larger, the D is smaller. So the relationship between the E and the S stays the same. They're inverse. Then when you get into the restricted, you again have the inverse relationship between a tall E, large E, small S, very small A, large D, and then of course you have your large R. Your reversal duration is prolonged and your velocity is increased. So that'll end our discussion this evening for week 2 of diastolic dysfunction and dealing with common patterns of mitral inflow and pulmonary veins. I suggest that you spend some time going over this, really studying the inverse relationship, the prolonged versus pseudo-normal versus left ventricular end diastolic pressure raise, increase, and the restricted. This is going to play a very large part in echocardiography in the near future. It's beginning to play a very large part in the near past and gets larger every day. So if you need some additional subject matter, by all means check your Feigenbaum book. You can also go to Google, go to images, videos, search for diastolic dysfunction, mitral inflow, pulmonary vein in restricted, prolonged, normal. If you find anything that you're unable to isolate or make sense of, please send a link or a copy to me at john@academyofultrasound.com, and I'll be happy to try to interpret it and help you interpret it. Other than that, continue to study, and I look forward to seeing you at our next session.